Jim?
Mm-hmm. Well, good afternoon and happy Friday. Jim Brett of the New England Council. Hope that each of you, as well as your families and colleagues, continue to be safe and healthy as we navigate these challenging times. I want to thank all of you for tuning in this afternoon to the second installment of the New England Council's Leading in a Crisis virtual event series. We launched this new series just a few weeks ago as a way to highlight some of the incredible leadership we've seen across an array of industries in New England, both to treat those suffering from this terrible virus and to help support our economy during these challenging times. Our hope is that these programs will help us all to learn from the experts in our region as they lead their organizations through this time of crisis. Our first event featured leaders in the life sciences industry, and today we'll hear from medical experts. In the next several weeks, we'll also hear from leaders from the energy and the banking sectors. New England, of course, is home to some of the most elite medical institutions in the world, and who are at the front lines of this crisis, both in treating patients and working to develop treatments and a vaccine. Well, today we're honored to welcome two of the region's premier medical experts to share their expertise. Our first guest is Dr. Nahid Bhadlia, world-renowned infectious disease specialist. She serves as an associate professor at Boston University School of Medicine and as the medical director of the Special Pathogens Unit at Boston Medical Center. She also oversees the medical response program for Boston University's Maximum Containment Biosafety Level 4 program at the National Emerging Infectious Diseases Laboratory here in Boston. In fact, in recent weeks, she's provided expert commentary for a number of local and national media outlets, including an appearance just a few weeks ago on Meet the Press. Our second guest is Dr. Paul Bittinger. He's the Chief of Division of Emergency Preparedness and Director of the Center for Disease Medicine at Boston, Massachusetts General Hospital. Dr. Bittinger has lectured nationally and internationally on topics of preparedness and disaster medicine. Over the course of his career, he's been involved with the response to other crisis situations, including Hurricane Katrina, Boston Marathon bombings, and the Superstorm Sandy. I would note this is the second time that both our guests have joined the New England Council to share their expertise in a public health crisis. Several years ago, they were both panelists at a New England Council program that focused at that time on the Ebola epidemic. Well, needless to say, we are incredibly fortunate that they were able to take some time away from their duties to be with the New England Council today. So, time is of the essence, so let's jump right into the discussions. We have an awful lot of questions. We have a limited amount of time for both doctors, so I'll try to the best of my ability to ask as many of these questions within the time frame. So for the first question, for most average Americans, we started hearing about the coronavirus in January. And I think to most, it was something of a faraway problem on the other side of the globe. Obviously, both of you, for your work, pay much closer attention to global health issues. So I am curious to hear at what point you started following this issue and at what point you realized this was going to spread and have a major impact here in the United States. Who wants to take the first question?
I'll let Nahid kick off.
Nahid? Okay.
Yeah, I think it's going to be very similar to Paul probably. So, I'm sure Paul follows the same thing, which is ProMed. It's a service that's, run and co-founded by one of our own fellow Massachusetts physicians and public health leaders, Larry Madoff. And I noticed the sort of the successive concerns about this virus in Wuhan in early January. And I actually shared that with our team at Special Pathogens Unit. And again, at that point, it was unclear, how widespread and how much human-to-human contact there was. But by the end of January, mid-January to end of January, we already had a working group at the hospital that's looking at what needs to be in place if we see patients like this, what kind of personal protective equipment it will take, and where will we place the patients. By beginning of February, I personally was traveling from from Boston to Uganda and Uganda to Liberia. And when you were not in the US, you were already feeling how much different and how much widespread this disease was already in Europe. You know, they started seeing cases in Paris, you know, as I was traveling through. So I ended up sort of commenting. I wrote an article in Nature around that about the lessons that we can sort of take from other diseases. It's funny, Paul, you and I, let's not make this a habit that it's usually a pandemic that brings us on a panel together. But I think it was around then, but I think even despite knowing some of the stuff was going on, the rapidity with which the cruel the cruel math of exponential growth of this disease. I would say most people, it took that by surprise, because by mid-March, you know, it was already here and much more widespread. We think at that point, looking backwards, there were probably already cases in Massachusetts in February where we're going to find similar to what we've seen in California and other places as well.
Yeah, I would agree with what Nahid said. I think it's interesting. If you read ProMed for the first time, it's terrifying no matter what's going on in the world, because there always are infectious disease outbreaks. And the new subscribers have to have a little break-in period where they get used to new threats. But I do agree with Nahid that there was something early on that was different about this outbreak. And we actually were on a trip to Israel in the early second week of January with folks in the Nebraska Biocontainment Unit and some federal government representatives. And we discussed already at that point what was happening. And all of us thought this could look a little different. That one of my Nebraska colleagues said, you know, this is how we saw SARS start. So there just was something in the way that it was really spreading, and I think quickly, as Nahid pointed out, as well as really the overwhelming demands it was putting on the healthcare system very quickly. And so much like Nahid, it prompted early action. And in fact, we activated our emergency command system for the hospital and for our enterprise on January 27th, long before there were ever cases in the US or in New England.
Yeah. You know, the United States is about 4 to 5% of the world's population, but we seem to have about 27, 28% of all the deaths and maybe 25% of all of the reported cases. So you do wonder, did we, the United States as a whole, get into this much later than other countries, Germany, South Korea, Taiwan? It's just interesting stat, to say the least. Dr. Bittinger, your job is to make sure that MGH, one of the largest hospitals in our region, is prepared for whatever emergency or crisis comes its way. When this virus first came about and started to spread, what steps did MGH take to prepare? And to what extent do the hospitals already have plans in place? You talked just a little bit a minute ago, but you go a little deeper on it. And what kind of scenarios did you have in place?
Sure. So you know, we have been planning for, as you'd expect, years and decades for this. And I'd say most of the US healthcare system started retooling pandemic planning efforts probably in 2003, 2004, because folks may remember that's when the bird flu, H5N1 scare was really the big thing in the media. And the federal government was really starting to push on increased pandemic preparedness. By that point, we'd also had SARS as an outbreak, which really, I think, made people understand how quickly a virus can spread around the globe. So between those two events, starting with SARS and pandemic flu, what again was called bird flu, we tooled up our efforts to enhance our personal protective equipment. We actually spent hundreds of thousands of dollars then on caches of supplies, masks, gowns, gloves, et cetera, which we've had to this day, and obviously now we're really, really grateful we had access to. We looked at how we would surge both our ICU and our floor care, and we looked at how we would use our staff differently to make sure we could care for people at the peak of illness. And you know, one of the things that was interesting is in 2009, when we had H1N1, people thought, well, this is the flu pandemic we've been planning for. And as bad as it was, and I don't want to minimize the outcome, because there were definitely, unfortunately, tragically deaths, it was mostly an outpatient pandemic where a lot of people were ill, but we didn't see the wave of critical illness that we expected. Unfortunately, with COVID, this is the critical illness that we were preparing for.
Mm-hmm. Dr. Padilla, You wear several hats at Boston University and Boston Medical Center, and one of them is Director of Infection Control at BU's National Emerging Infectious Disease Laboratory, which is one of the labs that's studying the disease and working towards a treatment. Can you tell us more about the work that's going on at the lab, and is there any progress that you can share?
Sure. Thanks so much, Jim. You know, I think with all emerging infectious diseases, what we've learned is it's a false dichotomy to separate research from clinical care, because the patients that you're taking care of with these diseases are teaching you about the disease. You know, and the first 100 patients that you see with this new disease tell you about how this disease sort of plays out. And so the clinical space and the research space are having to be a lot more aligned. They're not separate spaces. And that's reflected, I think, not just in the research that we're doing at BU and Needle and Boston Medical Center, but also at Harvard and Reagan and Mass CPR. And so a couple of the work, the specific stuff that we're doing, for example, is we're a partner in Mass CPR, the Mass Consortium for Pathogen Readiness. Needle is one of the partners in that, and Anthony Griffiths, for example, who is one of our virologists, works a lot on animal models and helping sort of understand this disease. Rob Davey does a lot of work on identifying new therapeutics by looking at everything that's been FDA approved out there. Could we find things that are now working at the cell level that could then be carried into the clinical space, you know? And so I myself am working with Rob to sort of figure out if we do find, promising candidates, how do you take that to the bedside? And then we're working on the clinical side. For example, I'm one of the principal investigators of a large prospective cohort that we're following of COVID-19 patients as part of a larger Boston consortium of cohorts that are bringing the data together. It's really meant to be collaborative because those larger numbers really help reveal phenomenon that we may not have seen before in clinical space. And then some of the other work that's being done is really perfecting antibody tests. John Connor, Jan Kepio, and some of the other researchers at BU are working with partners at Harvard, Galit Alter, and others to help answer things like, if you don't know how big this problem is, you know, either through diagnostics of acute infection or through measure of immunity, a reliable measure of immunity, we can't get a handle on responding to the crisis or what the philosophy of responding to the crisis should be. And so that's some of the work that I think not just what we're doing, but what we're doing across the city together to answer questions.
Yeah. 6 months ago, the term flattening the curve didn't mean much to most people. Today, you'd be hard pressed to find someone who isn't familiar with this concept. By your assessment, how are we doing when it comes to flattening the curve, both locally and nationally?
Well, I think locally, we've done pretty well. We are fortunate to have a group of healthcare systems engineers within my system that are incredibly talented at taking data and creating models for what we might expect. And we had access to a lot of hospitalization data from Italy. And of course, the Northern Italian experience was really among the most severe in the world. We were tracking our experience here in Boston and across New England against the Northern Italian experience. And the metropolitan Boston area in the first couple of weeks looked exactly like Northern Italy, in fact, a little bit worse. And it was within 1 to 2 weeks after we really started these physical distancing, flattening the curve interventions, we completely deviated from that curve. And so ultimately, the total peak number of patients that we had in our hospital, in our ICUs across Mass General Brigham, ended up being about half of what we predicted based on the Northern Italian experience. So it really did show that, 50% of hospitalizations, a significant number of deaths were averted because of these distancing and other interventions. Now, of course, the big question right now for everybody is how will we sustain these? I think, we have not, unfortunately, seen consistent application of these interventions and not consistent flattening of the curve. And, they've been incredibly important in the hardest hit areas, including, unfortunately, here in Metro Boston. But they're going to still be important as we go forward. And I am concerned that some of the short-term gains that we've seen that have been really powerful are not going to be sustained in the coming weeks and months.
Now, why is that?
I think there are lots of, political and economic pressures, obviously, to move forward based on fatigue or based on other drivers. and less so based on the data that we have. If you imagine that the epidemic curve, it kind of goes slowly before it really ramps up in that geometric fashion that Naheed mentioned. And what it means is that those early signals are subtle. If we're opening up too fast, we'll see increased emergency department visits, increased hospitalizations, increased positive tests. But by the time we know we're seeing a big increase, it'll be too late to act, and we will have lost that opportunity to flatten the curve. So we have to be willing to pay attention to more subtle signals, and that's hard to do given the very understandable other pressures that are at play.
Mm-hmm. Another term that we've all become very familiar with is social distancing. There's been different reports on how long it will be necessary to keep that social distancing practices in place. Some have suggested weeks, months, even several years. What are your thoughts on this much debated topic?
Yeah, I think that people tend to, there's a couple of things that are going on. As you mentioned, I've sort of been doing some science communication with the public, and I find that there is conflation of the terms of the lockdown that we've done, where we kept everybody on the inside, versus the term physical distancing, which I actually prefer to social distancing, because it's really pointing to the fact that you got to separate, you have the separation between people. Truth of the matter is, not most of us are not immune to this disease. And as Paul said, the likelihood is every time you open, and our own experiences here in the US, as well as in South Korea and elsewhere, every time you open, you will see more cases. And the only thing you can control is the number of people who get sick and the number of secondary people that they infect, and how quickly our systems sort of get overwhelmed, right? To do this successfully, to open up, you cannot take those engineering and infection control measures like physical distancing out of the mix until most of us are immune. I mean, it's as simple as that, right? There's no magical thing that happens one day where we all of a sudden become immune to it and we can open up and go back to normal. I think most public health folks will say that there will be a new normal between now and when the vaccine is not just available, but distributed to enough people. So we've built an immunity of about 60 to 70% is what, Mike Osterholm and others have sort of talked about based on what this disease is like. And so that means that for us to open up society to a certain point, to open up businesses, to open up life, we have to have those infection control measures, such as use of cloth coverings, maintaining physical distancing, engineering spaces where we conduct business, education, and care in such a way that people do not pass this on to each other, because that's what we control. We control the number of people who get sick. And so I would say, most public health people would say that I think that we will need those engineering and infection control measures in place until we get a vaccine.
Mm-hmm. Dr. Paul, do you want to expand on what you think?
I completely agree with Naheed. I think, it's all about opportunity. And if the virus has more opportunity to pass from person to person, then it will, because that's what it does. And so if we don't wear cloth coverings, if we have lots of people in close proximity to one another, because almost none of us are immune, the virus has a lot of opportunity to spread. And so as we go back to our lives, and I think Naheed again made a great point saying, we don't have to stay locked down per se, but we do have to live differently. We have to keep space and time around us in a way that we're not occupying the same spaces the way we used to. We can resume a number of activities that have been deferred in the workplace and otherwise, but we have to keep the opportunities for virus transmission low. The good news, for what it's worth, is if we do it in a graded fashion, then the prevalence is lower. And when the prevalence is lower, there again is less opportunity. So we can sustain our efforts and keep opening up in a gradual fashion. But if we lurch back and forth between rapid opening, therefore big increases in disease, and then have to clamp back down, I certainly believe that's much more painful and frankly, much more prolonged than a gradual opening.
Yeah, and if I could comment, Jim, I think that if we look at why did we put the lockdown into place? I think we put the lockdown into place because it was like an alarm button, an alarm sort of prices that we pressed to put all actions, human actions, on hold, because we didn't know how big the problem was. A lot of transmission had already happened without us knowing. And so the way to move forward is the reason places have been able to open, and they're still testing, wetting their feet in this and learning from it, is they drove the numbers down. And we did it because we can't stop the chains of transmission. There were so many people, there was no way to test everybody, no way to contact trace everybody. We drove the number of people who are getting sick to a much smaller number, which means that we can then employ things like testing, tracing, and isolating, which means we get a handle on everybody who's getting sick. So for the limited resources that we have, there just weren't enough, when this was a peak. With the limited resources that we have going forward, we deploy them to find every person who's sick, everybody else around them who might have had contact with them, and then quarantining them. If you put all of those people, within their homes again, you're creating mini lockdowns for only the people who could spread this disease. And so the rest of society can continue. And so aside from those engineerings, and so what does the engineering do? What does the social distancing, physical distancing, infection control, hand hygiene do? It is the public responsibility of doing the same thing, reducing that transmission. It is what each of us take on as that responsibility to not become a node of transmission for the epidemic.
And the hardest part of that message, I have to say, is that it's not about any one of us as an individual, it's about us as a group. Because certainly, all of us have heard from young folks who say, look, especially before the cardiac complications of kids were well known, they think I'm not really at that much risk of severe disease. But that's not the point. The point is that every single person, whether they're at high or low risk of severe disease, becomes an opportunity to sustain the outbreak. And so it really does rely on all of us to participate in these measures if we're going to protect all of us at the same time.
Some have suggested that we shouldn't reopen the economy until universal testing is available. Do you agree? And realistically, how far are we from universal testing being available?
So testing obviously is one of the biggest challenges we've had throughout this entire outbreak. Early on, really hard to diagnose the virus with a long turnaround time. And even since then, we've been trying to play catch up in terms of diagnosing each case when it first presents. I think, universal testing, I would argue we're not trying to test every single person in the state every single day. That's not the goal. The goal is anyone who has symptoms who possibly could be infected gets tested very quickly to facilitate what Nahid said, which is that contact tracing. We have to get the answer back to the person within 24 to 48 hours because really the best evidence we have says that if we don't do that contact tracing within 24 to 48 hours, then the infection spreads because by the time we tell people that they've been around someone who is infected, they've already spread the illness to someone else once or twice or more then. So it's really not just the number of tests, but actually the number of tests with a rapid turnaround and then pairing that up to contact tracing. Because again, if I happen to be the person that's infected and I've been next to Nahid, we have to tell Nahid before she passes it on to anyone else and have her quarantine at home, get care if she gets sick. But that's how we stop the transmission of disease. We're probably still not where we need to be within the Commonwealth to do that. But every week we're getting closer and closer.
Yeah, and the tough part of this is, as Paul mentioned, there's studies that now show that 40% of infections that people pass on, they do before they have symptoms. That means that it's already too late, and so it's already too late in some ways because they've done some of the harm, and that's why the contact tracing and quarantining people who are exposed is so important. But the second part, once we've reached that level, the second level of testing that we need is surveillance and high risk groups. And so these are healthcare workers who are going to come into contact with a lot of people who may have asymptomatic disease. And so they should be tested regularly, even if they don't have symptoms. What Director Redfield for CDC mentioned at the hearing on Tuesday is he wants to see surveillance in high-risk groups like nursing homes, like prisons, like, large areas where congregate living happens, like homeless shelters, where asymptomatic cases or cases where people have no symptoms could drive large outbreaks, and so having routine surveillance in those areas might help. I would add one thing that hasn't been discussed a lot that I would love to see a lot more of is actually more testing of people who pass away from this disease. We know that people aren't coming to care. There are a lot more people are dying at home. we don't know what percentage of that death is actually from COVID. You know, they may be coming in with late stage presentations of COVID that actually look like a heart attack or a stroke, and we don't know. And so what we did in Ebola, for example, to get a handle of how big the outbreak was, is we made that testing available for those who passed away as well, particularly those who had suspicious, you know, reasons for why that may have passed away. So we get a bigger handle on how big the problem is.
I believe Governor Baker indicated he wants to ramp up the testing to 45,000 a day, and by December, 75,000 a day. That would probably put him in the top 1% of the country in per capita in testing. So I think we seem to be ahead of the curve here, at least in the Commonwealth in testing. What about the role of contact tracing in controlling the spread? How important is it? And do you think it's an area where we should be focusing more resources?
I think so. I think it's because it is hard to do, and frankly, the consequences are hard to do. So I already touched on how quickly it has to be done, and that requires just personnel resources, as well as hopefully technology. There are a lot of people working on apps and other tools that will speed that up. But again, if you're going to break the chain of transmission, you have to do it early. Now, I think the other problem is clearly that it's not easy for everyone to quarantine. There are lots of people that cannot afford to just stay home from their job because they happen to have been next to someone who is ill. And not everyone is going to be able to make a good choice when someone tells them that for the third time they need to quarantine and they're at risk of losing their job. There also are lots of people in living situations where they cannot effectively quarantine. You know, part of what we've seen driving some of the inequality in this outbreak is that either quarantine or isolation, isolation obviously referring to when people are ill. We've had people with mild COVID who could go home and stay at home, but they can't stay away from other family members or others in their living situation, and then that spreads disease. And so I think we as a community need to find ways to support those who really struggle to either quarantine or isolate effectively, but because otherwise the interventions just aren't going to work.
Another question: the Boston area has, of course, been particularly hard hit. But at the same time, we're fortunate to have such incredible hospitals to take care of people. I know that both Mass General, BMC have been inundated with patients. Can you tell us about how the different hospitals have coordinated in recent weeks to manage the flow of the patients?
I'm going to put this to Paul because, you know, he's the head of the emergency response for a lot of the efforts for the state. I will say that one personal small way that I could tell you is, for example, remdesivir, the drug that was recently distributed by the federal agencies. MGH received some and you know, have been incredible in working with state to redistribute to ensure that hospitals, all hospitals that need it, get doses. So that's one way I think hospitals across the country, across the state have worked.
Yeah, I think, you know, I don't want to sound too saccharine about this, but we have worked together as a healthcare community in ways we never have before, and we were pretty collaborative to start with. I think we stood up across the city a daily capacity management group that was attended by either capacity or critical care physicians from every single hospital, including both Naheed's and my hospital, to talk about where there was capacity every day or where there were challenges. And this allowed us to make sure that even at the peak of the illness, when we had far more patients in the ICUs of Boston than have ever been in the ICUs of Boston, we still had places to go. And we shared ventilators. We sent ventilators back and forth among the hospitals. We shared other resources. And you know, these are normally reasonably competitive medical systems for all the usual reasons, but everyone needed to come together to be there for the community, and I think it was pretty extraordinary. One other thing that we did, both again, Boston Medical Center and Mass General Brigham hospitals contributed critical care physicians and respiratory therapists to assist the state with ventilator allocation when we received federal assets. We had more patients on ventilators across the state than we had ventilators during the peak of this outbreak. And we were using anesthesia machines and transport ventilators, but we actually did require additional federal ventilators and distributed more than 670 of them using medical experts from our hospitals to work with our state public health partners and make sure every hospital that had a need receive those resources. And you know, there's a lot to be proud of in how our community came together to respond.
It seems that every day we hear of a new trial for a treatment for this terrible disease, and various drugs are being tested. Do you think we'll see a treatment for COVID-19, or rather various treatments to alleviate some of the different symptoms in speed recovery?
Yeah, I can comment on that. You know,
Yeah.
so I think the reason why treatment's important is that we know the vaccine's not going to be coming around for at least a year. You know, we hope it might be earlier, but I think most people agree that even a year is a pretty ambitious timeline. You know, and so a treatment allows us to at least not have the bottom fall out so far deep that if people get sick, and particularly those that get critically sick, don't have a chance to survive. Treatments allow those chances to increase. And so I can talk about the drugs that are out there right now and in the way of how we understand this disease now works. There are a few things that happen. One is you have the virus. Once you get infected, the virus itself, you know, wreaks havoc on the system, does this damage, you know, it causes a direct sort of viral activity, but then it revs up your immune system. To the point where you see all these secondary things such as inflammation in the lungs that make it difficult to breathe, and you know, and potentially what we're seeing now is that it can create a propensity to create blood clots, and that leads to increased number of strokes, increased numbers of heart attack, you know, clots to the lungs, and so there are different parts of this problem, and different drugs will address different parts of that problem. So one drug, the remdesivir drug that you've heard a lot about, there is one of the first therapies that we've seen data from a large trial, the NIH trial, that we're still waiting to see the details of that data. We haven't seen the study yet, but we've been reported from the NIH that it actually reduces time to recovery and hasn't shown as much benefit for mortality. But when we look at that data, it will give us a chance of, are there subgroups, are there certain people that has more benefit in versus others? Drugs like remdesivir help with the virus part. They help block the virus. There's going to be, and there are already trials in works that actually help with the other part, which is the immune system revving up and all this inflammation happening. And there are a bunch of these drugs that both MGH and Boston Medical Center are part of that are helping address that. And the data on those, we hope will be coming out in within the next month or so. Then there's going to be a whole other class of drugs, some of which are actually a little bit more data on, which is convalescent plasma, which is basically you're taking the plasma of someone who's survived, it's like an immune blanket, and you give it to somebody who's sick. And there's some large trials going on with the use of convalescent plasma. Small trials have sort of shown benefit. A 10-person randomized control trial showed some benefit, but those aren't really numbers we can depend on. And so we're waiting for results from these large trials. There will be more specific drugs that take that concept, this idea that survivors may have some antibodies, some proteins that are targeted, that are very effective against viruses. Companies are now identifying, and researchers are now identifying those particular proteins or antibodies, and they're cloning them. And those drugs are going to go into trial potentially in a month or so, and we might see results from those by the end of the summer, we hope.
Yeah, and I think the other thing to point out is you know, we are all extremely hopeful for the therapeutics, and I think the work that's going on for these therapeutics is unprecedented in terms of scale and scope and speed. But also, frankly, just on basic clinical treatment, the same is happening. That there's a lot of argument in a good way about the best ventilator strategies to treat patients with in the ICU, because there is something very strange about this disease in the way it affects the lungs. Some people have coined the term happy hypoxics, which means people who have awful oxygen saturations. Their body is critically low of oxygen, which in any other part in my clinical career, the entire time I've been a physician, they would look at death's door and they look pretty happy and smiling and not really in a lot of distress. And there's no other disease process where we've seen that like this. So there's a lot to learn about the lung physiology. As Naheed mentioned, there's a lot to learn about the clotting. We don't understand why these patients make clots, and frankly, we don't yet fully have the data to talk about the best way to anticoagulate them. If we do it too much, we clearly know they bleed, and if we do it too little, they make clots. So there's a wealth of data being accumulated and studied right now about normal clinical interventions about the best ways to deliver critical care. And frankly, some of the early data suggests it makes a huge difference in terms of mortality. There are very, very wide ranges out there in terms of ICU mortality for COVID patients. And there's a lot of things that depends on, but I'm cautiously optimistic that we will quickly evolve to a standard treatment regimen that I think is going to be very beneficial for patients.
There are also, of course, efforts underway at various hospitals and life science companies to develop the vaccine. Naheed, you sort of answered this first half question. The Trump administration has suggested we might have a vaccine by the end of the year. Do you think that's a realistic estimate? And given that it would be likely to take some time to produce the number of doses necessary to vaccine everyone, how do you prioritize who gets the vaccine first?
Oh, I get this tough question.
Well, you answered that first half.
Yeah, no, we have some principles right around this, actually, from smallpox, from polio. Like we've gone through this when we get a disease that we're sort of looking at. Let me step back by saying what it is that's causing the timeline to be so long, right? So it's been blindingly fast. Bringing vaccine candidates, it's been like incredible, world records in how we've developed the platforms, we've identified the candidates. The thing that's taking the most amount of time, that will take the most amount of time, is testing it in the large population for its efficacy and its safety. And the reason why is you give the vaccine to a population and you wait for infections to occur naturally. And you want to make sure, A, that giving the vaccine actually reduces your chance of getting the disease compared to somebody who didn't get the vaccine. And two, getting the vaccine, because it's an experimental vaccine, you don't actually want to make the disease worse. Some other new vaccines, such as dengue, we've used in infectious diseases, for example, have had that impact where you had something called antibody-dependent enhancement, where it actually made the body's response worse. And that's why you need to take that time to be sure that there is not going to be that kind of impact. And that's why they go through that trial. And that's why it's taking that long. What's likely going to happen is that there are already like 6 or 7, maybe more candidates, that have gone through phase 1. Some of them are going into phase 2, which is looking at efficacy in smaller groups of people and safety. You're probably going to see multiple candidates moving into more advanced trials. And in the end, I think there'll be multiple global candidates for distribution. And so I think different countries are going to have to come up with the strategy. It's going to have to be a global strategy. What kind of upsets me a little bit is, there's a WHO group that was put together with all the global leaders to sort of talk about this, and the US was not at the table. What if ours isn't one of the candidates that's successful? Not being at the table puts us behind the curve to get access to the vaccine, right? And we need to take the global health leadership position of coming up with a plan of how we get this drug everywhere, because everybody, if there's an outbreak somewhere, there could be an outbreak everywhere, and so reducing chances of outbreaks occurring anywhere around the globe is in all of our interests. So the way that we approach, when vaccines first come out, the way that we approach this is we try giving them to the people who are at the most risk of getting the disease. And a lot of times, and this is what we did we did this in Ebola as well. So we start with healthcare workers, we look at those people who might be at risk, and then we start also, as Paul talked about, the contact tracing, right? So if someone's sick, you want to get everybody around them immune. And so a lot of vaccine strategies have involved looking at people who might be sick and then vaccinating all the contacts around them so they don't develop a disease. So you're breaking the chains of transmission with the vaccine. I'm using a vaccine as part of that strategy as well.
And I think, one thing that we have to be, or 2 things we have to be thinking of now are both the manufacture and the distribution. And I know both are being thought about, but, we cannot wait until we have a candidate vaccine before we start creating the manufacturing capability. We are going to need billions of doses of the vaccine, and that takes a while to get ready for the manufacturer. So there are efforts underway, but I think we need to make sure that they continue to be well supported and prioritized, because once we have a candidate vaccine, clearly getting it out in very large quantity is going to be important. I think, as Naheed said, there are long-standing principles of how you allocate vaccine, but I think we have to have a very, very important conversations when we do have vaccine to allocate. That there are somewhat competing differences when you look at who are the greatest spreaders and how you might shut down transmission in communities. even who's at highest risk of contracting the disease, because we know for sure that there are different populations who actually are at highest risk of adverse outcomes. This pandemic very, very clearly has highlighted disparities in healthcare and health status among communities, and has been really, really unfair and unequal in how it's affected different communities. And I think our vaccination strategy has to be equitable and has to address these disparities to protect the communities that have been hardest hit, and to really try and limit the ongoing damage that we still see.
There are some people in the medical community that say once that vaccine is up and running, they're fearful that there's going to be a shortage again of needles, syringes, and actually, helping the patients to recover. Is this something that you're concerned about, and is it something that people doing something about now? Stockpiling, the syringes and the needles and other materials that's going to be needed once the good news and vaccines are coming on board.
Yeah, I was going to say one thing you learn about when responding to outbreaks is the little things that break the outbreak, and I'll give you an example. Like, when we talked about the last time I was on, it was right before returning to Sierra Leone, and in that outbreak, testing was so important, and we got all the labs up to get testing done. And the thing that broke the outbreak that month was there was nobody to draw the bloods and transport them. And it took too long to transport. All the samples went bad. So you still had no testing, despite spending millions of dollars. All right. This is a perfect example of a pinch point. And Bill Gates has actually commented on the fact that he foresees the medical glass is going to be a shortage, because the vials that contain the vaccine, that's one shortage. The other, as you said, is syringes. So there is this Project Warp Speed that's been put together by the White House. And one of the things that they are looking at is actually stockpiling and putting together stocks of pre-filled syringes for vaccines. And so I think that's going to be helpful. But then it will be everything. I think we're going to have to work on supply, like the cold chain, maintaining some of these vaccines will require to be at a certain temperature. How do we ensure that we quickly get the vaccines and safely get the vaccines without losing their efficacy? And we have good experience with that. We just need to make sure that we do this consistently for all the vaccines that are going out, given the number of vaccines that will go.
Right. There have been calls for those who have recovered from COVID-19 to donate plasma to help support finding a cure. Can you explain it in a layman's term how convalescent plasma can help treat this virus?
I like Nahid's term of an immune blanket. Basically, you're taking the antibodies from those that have recovered and helping to share those and other substances with those who are still fighting the virus. So, it's basically taking their immune response and making it your own. We don't know yet what the efficacy is, as Nahid said, but cautious optimism that it may play a role.
A couple other questions, because I know time is of the essence here. There's been some reports that individuals with serious health issues unrelated to COVID are hesitant to seek treatment because they're concerned that they might end up infected if they go to the hospital. What would you say to those individuals? And can you explain what steps hospitals are taking to keep those who are in need or urgent treatment for other health problems protected from the virus?
Yeah, I think this is one of the most concerning side effects, if you will, of this outbreak, that emergency department volumes are down by 40 to 60%, which is just very clearly not possible if you look at the kinds of cases that come to emergency departments without an adverse consequence. So there's some data from northern Italy that suggested that there was one excess out-of-hospital death for every in-hospital COVID death. And some of that may be COVID, but a lot is not. There's already data emerging from different parts of the country, including New York City, about excess mortality in the home setting, not in the hospital setting. So, I think it's extremely important for hospitals to be able to explain to the public why it's safe to get care in the hospital. I'll tell you, everyone in the hospital setting now wears a mask. We call that universal source control. That means patients, that means clinical staff, that means every single person in the hospital everywhere. We, in our own system right now, have hospital staff attest every single day. They get on a smartphone app to the fact that they have no symptoms. And anyone who has even the mildest of symptoms doesn't work. We have extraordinary cleaning procedures in the hospitals, but I think to me the most compelling argument is that we really do know how to take care of COVID safely. We have very, very good data supporting our employee health in the healthcare setting. We look at seroprevalence among our healthcare workers. We very closely analyze data of any healthcare workers who develop COVID, and there's absolutely no evidence that our clinical staff, any staff who work in COVID units, have higher risks of transmission of disease as compared to anywhere else in the hospital. What that means is that we're not transmitting COVID in any appreciable way in the healthcare setting. It's definitely safe to get care, and people need to be prioritizing their healthcare. And I understand completely why it's scary, but we're facing a big health crisis if people don't get healthcare. You know, preventable vaccine diseases, vaccine preventable diseases in children is just one, but we're way behind in pediatric immunizations right now.
Yeah, and I will only add that part of why we want to drive the COVID cases down at the community level in the hospital is to allow the rest of the healthcare system to open up. And it has done that, you know, by reducing the number of other cases, that the stress that COVID is placing on the system. It allows us to go, you know, we're always providing excellent care. It goes back to having more resilience to take care of everybody else.
Can I just ask another question? Do you think we'll be wearing these masks at Christmas?
Yes. I wish, I don't want to say yes. I think all of us, I have as much magical thinking as anyone else that I want to click my heels and go back to the old world. But I think until we have a vaccine, I think it's going to be an important part of limiting disease transmission.
Unless we come up with some new innovation that allows us to do disinfection, you know, in closed spaces. I don't think even then it will go into our homes. Likely you might see that in large, you know, places like consumer stores or hospitals or schools. But in the individual setting, I mean, when you go to Christmas, you are there with your grandparents, you are there with people who are potentially vulnerable and people of every age, some who might be young, who might be asymptomatic, and they may not know. And so we wear the mask to protect the people that we love. And that's why I think it's going to be important.
Just another question that I read somewhere where a medical doctor took all the right precautions, the gloves, the mask, and he came down with the COVID-19. And he said, where the origin of the virus, he said, was a droplet landed on his eye. And I found that interesting, because I said to myself, are we going to get to the stage we're going to have goggles on our eyes? I never heard of that being one way of transmitting the virus, a droplet on your eyes. Have you heard that before?
So it's actually all mucous membrane. That's, you know, so what you potentially do is you get it in your eye and then you're rubbing your eyes with your hands and you're transmitting it to your nose and other parts of your mouth. But yeah, all of these are at risk in terms of transmitting the disease. And actually, funny you should say that. I have a colleague, Eli Perenkovic, who's one of the ID docs out on the West Coast, who promotes this idea of face shields. You know, there's just some sort of barrier on the face rather than masks, or in addition to masks, having this barrier, because when you are most vulnerable is when someone is speaking at you or coughing at you, you know, and you're in their close proximity. And so a barrier of any sort that helps you protect from those droplets with bodily fluids are what's going to keep you safe. You know, I don't know how it can be operationalized at a large scale level. I mean, the way that you prevent that is you keep this physical distance. You know, if you keep the physical distance, you hopefully don't need the face shield for close contact.
And I think, yeah, exactly. You know, and we now know this, right? So the recommended personal protective equipment in the hospital for healthcare workers is indeed eye protection when you're caring for a patient with COVID. So people wear goggles or a face shield. You know, in the public setting, as Naheed said, because hopefully we're all wearing masks, that's decreasing the amount of fomites or particles that are traveling away from the person. I think any individual member of the public should not be so concerned. I don't see us moving to a recommendation of goggles in public, but especially for us in the medical community where I may have to look in your mouth, you may have to take off your mask. I need to be wearing goggles in that setting.
Do we know the origin of the virus?
Well, I think there is pretty good scientific consensus that this happened through some sort of natural event that we call spillover, which is when a transmission transfers from a wild animal into either a domestic animal and then to humans, or directly from a wild animal into humans. And currently, the thought is that this virus is akin to a lot of viruses we find in bats. The evolution of this virus, when you look at the sequence of it, its evolution follows the path one might see naturally. There's a lot of mistakes. What you see in natural evolutions is that there are a lot of mistakes, and then recorrection and mistakes and recorrections. And so you don't see a very efficient path in the map, the genetic map of the virus. And that's what we know with this as well. The one thing that we don't know is that how did it get transmitted directly in this case from animals into humans? Was it through a domestic intermediate host or another intermediate host? And pangolins have been sort of quoted in that. To my own chagrin, because I'm a cat person, cats have been quoted in that. So that's sort of the question of whether there are other sort of in-between intermediate hosts that we haven't identified.
I just have two more questions, and one has already been touched on. One of the biggest challenges for hospitals has been the shortage of PPE, the masks, the face, the shields, the gowns. In the future, will we see hospitals stockpiling those types of supplies? And should the federal or the state governments maintain their own stockpiles in the event of this future pandemic?
So I think we absolutely will continue to stockpile. Again, my own hospital, what we had previously targeted as a 2-week stockpile that we thought, if a pandemic is 8 to 12 weeks, we wanted to get through the worst 2. Based on this experience, I think we're going to have 3 months probably worth of stockpile. And clearly, the federal government has said that they will be replacing and expanding their own stockpile. I will say actually that my belief is certainly that we should stockpile, but there is no warehouse large enough to have responded to an event like this, even in retrospect. That when you look at the usage needs across a country like ours or across the globe, and the unmet needs in nursing homes, in EMS, in so many other settings that still exist, it really has to be met with pairing that up with manufacturing. And I don't love a lot of military analogies related to this outbreak, but I think for this case, I make an exception. We would never expect that the military would go to war with just-in-time manufacturing of bullets or guns or anything that they need. They have an ability to significantly scale up when they need to make what they need under crisis. And it's the security of our nation, it's the health security of our nation that we need 3M and others, I'm not picking on them by any stretch, to be able to ramp up by 50 or 100% when needed for N95s, for gowns, for gloves.
Yeah.
I think we have to have a focus to a degree on domestic manufacturing as part of our national strategy. But we have to find the incentives to build it in for them to be able to ramp up quickly and make what we need.
Yeah, one thing I'll add is, well, 2 things I'll add. By the way, perfect things. Infectious diseases, doctors shouldn't be touching their face. I'm just moving cat hair. The 2 things that for me, are just striking is we already knew by 2014 that there's been no innovation in personal protective equipment for decades. And some moves were made, but even then, here we are, worldwide pandemic, and we're still stuck with the same personal protective equipment that we're using that is so uncomfortable for healthcare workers to use, that reduces the quality of care we can provide to our patients. It limits the time we can spend at the bedside. And what I'd really love to see is national investment in innovating personal protective equipment to improve all those elements, And the other thing that I think we might see that it needs to be stockpiled, but aside from that innovation, I would love to see just innovation of all of biocontainment care. We've done, Paul and myself and others who are part of this national network called Emerging National Ebola Training and Education Center. We've talked about each of our units working on improving engineering and technologies that help take care of patients who cannot, for example, potentially, whose care may be limited in some way because they have these infectious diseases. So, for example, stethoscopes that are wireless that are actually good, so you can, get a good sense of hearing this person's ear through everything else that you're wearing, right? What I'm hoping is that we'll see both innovation in personal protective equipment, but also those types of engineering sort of stuff that improves the care of the patient.
Well, Congress is now looking at breaking up that supply chain that they had to rely on, in particular in China, for materials and medicines. So they're looking at maybe giving some tax incentives for manufacturers here in the United States to produce so many of these products, because I think they learned that this is a very dangerous way of trying to access supplies with different parts of the world, that we ought to be doing it ourselves. So hopefully they'll come up with the right language and the incentive for manufacturers to say, count us in. We'll be the manufacturer of these materials, and hopefully it'll make a world of difference. The final question really is, even though we're still in the midst of this crisis and not at the point where we can look back and assess, but what would you say has been the top lessons you've learned so far?
Well, I'll start with maybe some positive, which is the preparedness matters. I think we're nowhere near being able to declare victory. There's a lot going on, but I think especially our healthcare system in Boston, having planned for this, having cooperated, having a lot of resources in place with personal protective equipment, caches, training, other things that we were able to mobilize care resources in a way that I think we should feel proud of, and it results from years and years and years of planning and preparedness efforts. I think the other big lesson right now is the value of scientific collaboration, and Nihito, I'm sure will say more. We and particularly we here in Boston have been able to work together to learn lessons, to identify solutions, whether it's lab testing, whether it's other kinds of clinical care interventions, at a pace that we've never seen before in medicine. And showing that that's possible is something we really should continue to build on going forward.
Yeah, I think everything ditto on everything Paul just said. I think the other parts are, it's always good to overreact. There's this continuous struggle between public health and economy, which I think in some ways is a false dichotomy, right? Because one thing that Mike Ryan said, the director of the WHO Emergencies Coordination Unit, was, well, we don't want to be is in this vicious cycle where we open up and close and open up and close, and we close because now the cases have gotten to be so many that it overwhelms the healthcare system, and all the money that we put in for building the stimulus package and everything else goes to waste because we have to close up again, and so the importance of doing it right the first time, or doing it right enough so that you don't have to keep closing, maybe it takes a few iterations, I think, and what that takes, I think, aside from public health and economic leaders and political leaders working together, I truly think for me that one of the biggest lessons is that it really falls on all of us. It really, for us to continue vigilance, for us to protect ourselves, for not just our own health, but the health of others. The personal responsibility part of this, I cannot stress enough, because the ebb and the flow of this pandemic is decided by every individual. It's not just, yes, public health has big measures and politics plays a big role, but it's really us, because you have events, for example, you might have heard of this choir practice somewhere in Seattle where like one person infected 28 other people, without even realizing they were sick, and they made everybody else sick. And so one person leaves a huge footprint. One community leaves a huge footprint. One state that opens up too early leaves a huge footprint on the rest of the country.
Well, we come to the end of the hour, and I just want to be respectful again of our guest time, since they obviously have very important work to get back to. But this has been an incredibly informative discussion, reassuring to know that we have such incredible leaders in our region working to solve this crisis. So I just want to thank both of them, Dr. Bedelia and Dr. Binninger, not only for taking time today, but for the incredible work they and their colleagues are doing here. To me, they're heroes. So, and of course, I just want to thank all of the people in the front line that are doing this extraordinary work day in and day out. So this is what makes New England unique, and these extraordinary New Englanders. And again, I just want to thank all of you for tuning in today. Just a reminder that we have some more great programs in store next week. We'll hear from Congressman Seth Moulton on Monday, the Federal Reserve Bank of Boston President Eric Rosengren on Tuesday. And then a little switch, we have the political analyst Charlie Cook, who will be speaking on Wednesday to members of the New England Council. So we hope that you will join us. Again, I just want to thank our guests today for an incredible, informative, enlightening, but also, to me, inspiring discussion. So to everyone, have a great weekend and be well. Thank you.
Thank you.
Thank you.
Thank you.